السلام عليكم ورحمة الله وبركاته. I'm Ayman Saad, consultant hematology, King Faisal Specialist Hospital and Research Center. I have Dr. Hussam Al-Saadi with me, consultant in الحرس الوطني Riyadh, who will be chairing this session. So, Dr. Hussam, you want to start?
Okay. Assalamu alaikum wa rahmatullah. Good morning, everyone. It's a pleasure today to welcome you all to SSBMT meeting here in Riyadh. And our first speaker, my honor to present our first speaker, is Prof. Antonio Risitano. Prof. Antonio Risitano, he's a director of hematology and hematopoietic stem cell transplantation at Aron San Giuseppe in Avellino, and he's a professor of hematology at Federico II University of Napoli. After his education at Federico II University of Napoli, Prof. Risitano spent 3 years at hematology branch at the National Institute of Health in Bethesda, where he dedicated to experimental work on pathophysiology of bone marrow failure syndromes under guidance of Dr. Neil Wang. In 2004, he moved back to Napoli, where he served as a research associate and then assistant professor in the hematology unit, focusing on PNH, aplastic anemia, as well as of stem cell transplantation. From 2010 to 2020, he was director of bone marrow failure transplantation unit and associate professor of hematology at the Federico II University before he began appointed as a head of hematology in Avellino in July 22. Prof. Risitano pioneered in the development of novel treatment for aplastic anemia, PNH, through the seminal preclinical and clinical works. Welcome, Prof. Risitano, and it's the floor of you.
Welcome everybody, this is Antonio Risitano on behalf of the EBMT of the European Society of Bone Marrow Transplantation. I'm really privileged to be here with you, even if not in person, to share at the Saudi Society of Bone Marrow Transplantation our experience on aplastic anemia, discussing in detail the evidence, the data that we have to make a treatment decision between two different treatment options, which are bone marrow transplantation and immunosuppressive treatment. So, as you know, aplastic anemia was a disease characterized by very severe prognosis. You see here some data showing that this disease was eventually lethal in most, if not all cases, in the 70s. So I think this is something that we have to keep in mind when we discuss, even with patients, the current available treatment, which eventually completely changed the paradigm of this disease and eventually drastically changed the very dismal prognosis that we had in the 70s. Indeed, again in the 70s, this was one of the first diseases where transplant becoming a possible treatment option. I don't want to give you details of this very old data by Bruce Camita and Ryan Stoll, because of course this is just history, but I just want to highlight the fact that even in the 70s, we were able to cure patients by bone marrow transplantation, and this was eventually better as compared with the treatment, the non-transplant treatment that at that time was including just steroids and androgens. So of course, this is not a randomized data, but this is just to show you that even in the 70s, we had some evidence that bone marrow transplantation can cure aplastic anemia patients. Then this experience was reproduced in Europe, and these are the seminal papers where, for the first time, we had a very, they had a very strange observation that despite of, I would say, failure of the transplantation, patient may have autologous reconstitution eventually being cured by the disease. This was eventually suggesting that immunosuppression by itself can improve the hematological response of this condition, and the stem cells from the donors were not essential, meaning that the IST was able to stop the immune attack, and residual hematopoietic stem cells of recipient origin may eventually rescue hematopoiesis of the patient. These were the initial observations. Since then, formal trials were start mostly at NIH, and you see here, you may see here that ATG, anti-thymocyte globulin, became a very effective treatment for aplastic anemia, resulting in survival higher than 60%, with, I would say, a vast proportion of patients, about 2/3 of patients, having some hematological response. Of course, the patient also required chronic maintenance cyclosporine after ATG. And well, so we are in the 80s and then in the 90s, and we had two very good options that may result in a survival rate of about 70%. And these are some old data from the EBMT showing that both treatment options are very good for this patient. But I mean, we should try to understand, to tailor the treatment for each individual patient to see how we can do the best for each individual patient. So the question remains the same since many decades, whether we have to offer transplant or IST to this patient. And of course, I'm focusing now on first-line treatment, because now I would say it's quite well accepted that once a patient fails IST, the second-line treatment could be transplant. But I mean, as first line, we really have two very good options, and we should try to investigate the factors that may eventually drive and shape our treatment decision. Before going more evidence about how to select the most important factors, I wish to remind you this very old, well, not very old data, this data from the NIH showing that the outcome improved a lot in the past decades. And this was not only seen, you see on the left side, in responders patients, but this was even more evident here in non-responder patients. You see how we improve from basically 10 to 20% in the late 80s to almost 60% survival in the most recent patient receiving IST at the beginning of this century. So this is very important because we are able to keep patients alive. This is mostly because we have better anti-infectious treatment. I would say especially treatment for fungal infections. So now that we have better option to keep patients alive, of course, we have to treat the disease, and we have to try to find a way to have the hematopoiesis being restored from the immune-mediated death. And now, if you see the most recent data, and you compare this one with the initial natural history of Kamita's data in the 70s, you see that on the left, if you use IST and eltrombopag, this is the first phase 2 trial from NIH, you see that at 2 years, the survival is very high, 97%. And similarly, in patients receiving transplantation, these are the UK data using the FCC protocol, survival may be as high as 90%, even in unrelated donors. So we do much better than 50 years ago. I think this is the very strong message that we can deliver to our patients. say that, of course, we should do the best for each individual patient, and I will go through some data from the EBMT, eventually helping you in treatment decision. Of course, when we discuss transplant versus IST versus non-transplant, the issue is that if we choose IST, we may have less early mortality, but in the end, we could be worried about relapse, clonal evolution, I mean myeloid malignancies, and other side effects. Vice versa, if we do transplant, the issue is not too much relapse, but rather transplant-related mortality and morbidity, starting with GVHD and other problems that you are very familiar with. So let's pay attention to the most recent EBMT data from patients receiving transplantation between 2010 and 2020. You see that we are talking about many patients, 3,500 patients, and you see that broadly the survival is around 80%, which are amazing data if you once again remember Kamika's data in the 70s. These are the cause of death, so of course infection and GVHD are the most important cause of death. But do we have any factors that are associated with increased or reduced survival? Well, let's see. We did progress over time. So these data are much better than the ones from the previous century, but even in this 10-year period, you see that there was a slight improvement over time. Then we came to the most important predictor of survival, which is age. This is univariable analysis showing that basically we lose almost 10% every 10 years of patient age. And while data are very, very good in patients younger than 40, we'd expect survival largely higher than 80%. In patients who are 50 or older, you see that the survival is around 75%, which is not bad in the end, but is definitely worse than in younger patients. And of course, as I will tell you later, we have to imagine the same survival using IST for this patient group. But age is not the only predictor. Of course, the type of transplant, donor type, largely affect the outcome as well. You see that the best outcome as expected are with matched sibling donor and matched unrelated donor. So you need a matched donor, which means for this analysis, 8 out of 8. And well, results are not very good with unrelated, mismatched unrelated donors, and I would say even worse with haplo donors. These are real life data. So when you do an haplo donor, you have to realize that the expected survival is not higher than 60–65%. When we did multivariable analysis, you see that different factors affect the outcome. Age was the most important, donor type the other one, and also in some way GVHD prophylaxis may play a role. Of course, SOROR index was also, comorbidity index was also playing a role. Whereas previous IST seems not to affect too much the outcome. And as I said, also the period of transplant was affecting the outcome. We looked at the impact of age for each donor type, and I think this is informative in treatment decisions because you see that, for instance, in matched sibling donor, patients younger than 40 are doing pretty well, and this is eventually, these are data justifying our treatment algorithm, which recommend transplant upfront for patients with a matched sibling donor who are younger than 40, whereas, you know, these 60 to 75% survival is not the best if patients are older than 40, and you may eventually wait a little bit. If you do the same analysis in if you look in this patient population for the impact of GVHD prophylaxis, you also have the observation that CAMPA and PTCI are the ones who give the best outcome. So for sure you should include a serotherapy. ATG is apparently a little bit inferior to CAMPA. PTCI could be an alternative which seems equal to CAMPA in terms of overall survival. We did multivariable analysis, and you see that eventually the most important, the only factors eventually affecting the outcome are age of the patient, high comorbidity index, and prophylactic regimen, and you see that CAMPA was the one performing the best. We did the same analysis for unrelated donor. You see that all curves are a little bit lower as compared with matched seedling donor, and you can see here that in any case, again, between 40 and 50, you have some drop in survival. But the information here is that very young patients, younger than 18, are doing pretty well even with unrelated donor. And this is the reason why, if we are able to have quite quickly an unrelated donor, we tend to recommend upfront transplant even from unrelated donor in patients younger than 18. Again, if you look for the impact of GVHD prophylaxis, CAMPA seems the most important, the best GVHD prophylactic regimen, performing better than PTCI. Please pay attention to this, even if these are retrospective data. And this is confirmed also in multivariable analysis, where age and GVHD prophylaxis are the only factor remaining significant in predicting a better survival. When we move to unrelated donors, mismatched unrelated donors, you see that survival is not very good. So here we are largely below 80%, and I would say that this should not be recommended as first-line treatment to patients. Here, we still have the impact of GVHD prophylaxis, but no major finding in multivariable analysis. Don't forget that, of course, here the sample size is much lower. And when we move to Aplo, well, okay, this is a possible treatment as suggested by American data, but please pay attention here that the outcome in patients older than 50 is very, very dismal. So this could be an option, not necessarily as frontline, even in children, because the survival is below 80%. And in multivariable analysis, the only factor affecting the outcome was age. Of course, we could not investigate GVHD prophylaxis because all patients included in this analysis were receiving PTCI. So these are the data with transplant. Let's see the other face of the coin. And these are the data from the prospective randomized RACE trial, the EBMT trial, comparing standard treatment, standard immunosuppressive treatment, ATG and cyclosporine, with or without eltron. This is the treatment design. These are, I would say, the data are published in the New England a couple of years ago, so I would not spend too much time on the details. I just want to highlight that finally we included 205 patients and 197 were eventually analyzed for all the primary and secondary endpoints. And as you can see here, the response rate was much higher in patients receiving a thrombopan, arm B. The primary endpoint was achieved, complete response at 3 months higher than 21% versus the 9.9% of the standard arm. And this difference was still evident at the 6 months time point. When we used the overall response NIH criteria, you can see here that we have response rate of almost 80%, which are not different from the one seen in the phase 2 NIH trial with triplet. These are the most recent data. This is the final data of the trial, looking at response at 2 years, and you see that there is still a difference both in terms of complete response and overall response. So complete response rate is pretty high, is higher than 40%. And you see here the reasons for treatment failure. And the most important difference is here in green. Basically, it was the patient not receiving and not achieving a response, some hematological response. Here you see the cumulative incidence of hematological response. I don't want to give too many details because they are already published, but I mean, this just highlights the fact that response with a thrombopag arm B here are not only better in terms of quality, but also quicker. And it is very important because you reduce the time when patients are at risk of lethal complications. In multivariable analysis, treatment arm was not the only factor affecting the response. Age and disease severity were also playing a very important role. Overall survival was pretty high. I mean, it's around 90% in a randomized trial, so multi-center trial, not like NIH. And you see that was 91% versus 86%. We are just at the borderline for statistical significance, and the factor affecting overall survival significantly affected the overall survival, where treatment arm borderline, and this is good. Of course, there was some effect of age, and you see that this is more evident in patients receiving standard treatment, because then patient received a thrombopag did much better, irrespective of the age. And when we look for disease survival here, the difference is statistically significant because we have 36% in the standard arm versus 54% in the thrombopag arm. The difference was eventually due to the first year of treatment, if you look for the treatment arm, and age was also affecting the disease-free survival. It's very important to look at the specific reasons of causing the survival, I mean, affecting the survival, and we did it looking at the event-free survival, where you have 52 versus 48%. And again, this was associated with the treatment arm, the initial 12 months treatment, as well with age. And when we look for the reason causing the event eventually resulting in treatment failure, you see that the highest difference is here in green again for the response rate. So the proportion of patients not achieving a response was statistically different between the two populations. We also looked for IST discontinuation relapse. Of course, these data are not mature because you should look at them at much longer follow-up. 2 years is not enough. We looked for additional treatment and we could not find any major difference. And you see here that the most popular treatment was a thrombopag because patient in the treatment in the etombopag arm received additional etombopag in case of relapse, whereas patients who have not received etombopag in the standard arm received etombopag because of lack of response. Clonal evolution, well, we have just 3 patients developing some myelodysplastic syndrome according to the WHO criteria, 2016 criteria, so there was no major concern about that with the 2-year follow-up. We also looked for a somatic mutation in this patient, and we proved that the proportion of patients with mutation was about 30% at baseline, then it increased to 56% and almost to 80%, with no difference between the 2 treatment arms. You see here by specific genes, the most commonly mutated genes were, I suspect, the EBMT and PGA and BCOL, and there was no major association with any clinical outcome. These data are impressed in the New England Journal of Medicine evidence, so if you want to see more details, you can look those data. I just want to highlight here that there was no impact on overall survival, so mutations were not associated with improved or worse overall survival. There was no standard dynamics of the most commonly mutated genes, PGA, DMTTA, BCOL, and ASXL1, so there was just some minor increase, but you see that we are below 2%, so very small clones which are just sitting there. And if you go even down to detect clones with a lower BAF, you see that basically 99% of patients have some mutation, and they remain more or less stable over time without resulting in any major expansion. There was no specific association between different genes mutated in the same patient, so we could not find a typical co-occurrence or even some mutual exclusivity. Very few patients developed PNH, so this data eventually confirmed that what we are doing is pretty good. In children, basically you have to include 2 major criteria to take therapeutic decision: age and the donor type of donor. In children, if they have a matching sibling donor, you move to transplantation. Sometimes if you have already matched unrelated donor, you may also start with unrelated transplant. Otherwise, they receive immunosuppressive treatment, and eventually, in case of treatment failure, they may have transplantation from any donor. In adults, which means patients of 40-year age or older, you start with transplantation only if they have a matched sibling donor. Otherwise, you offer immunosuppressive treatment first, and then in case of treatment failure, I would say preferentially you move to transplantation from any donor. And of course, in case of relapse, you may still consider second course of ATG, but maybe because of the transplant data and the chance of cure, I would offer second-line transplantation instead of second course of ATG. So with that, I will stop here. I wish to thank everybody, and especially a number of mentors from the EBMT, like Aldo Past Working Party Chair, Andrea Bacigalupo, Judith Marsh, Jacob Passwell, but also people like Gerard Saucier and of course Neil Young from NIH. The most recent chairs, Regis Perfaut-Latour, Carlo Dufour, who are basically the masters as persons, not only scientifically. We did many things together, also with Osin Kulasikararaja from the King's College, and the tremendous EBMT staff with severe aplastic anemia staff, the statistician Dirk Jan and Simona, as well as the data manager Brian. And with that, I will stop here and I will take questions in the live session. Thank you very much for your attention.
Okay, thank you, Prof. Risitano, for the excellent and comprehensive presentation. And because of the time, we have time now for question. He's live with us now, I think. Any question from the audience?
Thank you for the excellent presentation. My question is regarding using TBO or Termobag or other drugs post-transplant. Do you think it will have a benefit similar to what we see with immunosuppressive therapy?
Can you hear me? Yes, I think so. Which drug are you talking specifically? Sorry, I missed the name of the drug.
Stem cell transplant. Does it have benefit?
Yes.
We have seen with immunosuppressive therapy.
Okay, no, I mean, I cannot say that we expect some benefits from a thrombopag in this setting after transplantation. However, irrespective of the indication to transplant, we have some experience using a thrombopag in the context of poor graft function after allogeneic transplantation. Again, irrespective of the initial indication. And we see some benefit. It works, I would say, more or less like GCSF. And we were able to rescue some patients with chronic poor graft function after transplantation. I have to acknowledge that we try to identify the patient who may have the highest benefit depending on the cause of the poor graft failure. And well, basically, if you have, let's say, a graft failure, a primary or a secondary graft failure, a thrombopag alone is not able to have. If you have just a poor graft function, mostly associated with, CMV infection, CMV treatment, or a little bit GVHD, well, in those cases, you may have some benefit. But if the reason is, for instance, not enough stem cells given at time of transplant, the benefit from a thrombopag is limited. There are also some experiences using different TPO mimetics. Results are more or less in line with that. So the final answer is that yes, we may expect some benefit, but if the graft is not good enough, basically even a thrombopag is not enough to rescue that bone marrow.
Question? Yes.
Regarding the data of Cambath that we saw, it has like better outcome compared to other GVHD prophylaxis. Does the working party recommend the use of Cambath or over the other drugs for GVHD prophylaxis?
Well, thank you very much for this question. As you know, nowadays it's not easy to make recommendation because when you do guidelines, you should follow, a very rigid methodology. We can just describe what we have. We have to acknowledge that the UK, the Campath experience is mostly coming from UK only. And now with this retrospective data, it looks like that we have some benefit. However, the access to Campath is not easy because you have to go through a compassionate use. So I think we can strongly recommend to use either Campath or ATG or PTCI, depending on the type of donor. Apparently, Campath is superior and is, if you like, a very easy platform that you can use irrespective of the donor type, because at least in matched sibling, matched unrelated and mismatched unrelated, it performs better than ATG. For Aplo, as you know, we use a common platform, which is the ZER platform with PTCI plus ATG and plus TBI. And then after transplant, a calcineurin inhibitor and mycophenolate. So we have to stick with that. I would say that my preference is for CAMPAT if you have it available in your centers. Otherwise, you can continue to use ATG. And unfortunately, we tried many times to have a study, either randomized or a prospective non-interventional, and we didn't succeed to generate a more robust evidence. We are trying to have some retrospective study looking specifically to this question, but this is not completed yet.
Move to the next presentation speaker.